gentlemen, please welcome Chief Strategy Officer of Rendina Healthcare Real Estate, Mr. Mike Noto.
Thank you. I should follow that up with, they give me a handheld microphone. That's very dangerous. I'm about to break out in New York or something. Anyway, so thank you all for coming. For those of you who were at the JLL Capital One parties last night, you bucked through it, you showed up. The rest of them, I don't know where they are. So thank you for coming. Revista, Mike, Hilda, Elisa, great job, terrific conference. Thanks for inviting us to participate, really appreciate it. And before I introduce everyone, I want to thank the panelists for volunteering their time and sharing some of their thoughts, so thank you very much. By way of introduction, to my immediate left is Brian Gitlin, Associate Vice President, Real Estate for University of Miami, UHealth. Next to him is Dr. Amit Rastogi. Dr. Rastogi is CEO of Jupiter Medical Center, world-class community hospital right here in Jupiter. I can vouch for the quality of their care in as much as me, my family, we've all been treated there. And I will say this, and no disrespect to the rest of you guys, the best hospital food ever. Next to Dr. Rastogi is Terry Wood, Vice President, Real Estate for Kaiser Permanente. And next to him is Dr. John Milne, which I didn't know John was a doctor, so I learned something today right away. Senior Vice President, Real Estate Strategy and Operations for Providence St. Joe's. So we have up here a real, I hope you appreciate the diversity of the panelists. We have the fully integrated Kaiser, we have the world-class academic medical center in UHealth, we have the National Health System in Providence, and we have the world-class standalone Jupiter Hospital. So it's, hopefully we'll get some varying answers, different answers to some of my questions, reflecting where they are and what they're doing. So first question is, I'm going to start with Brian. Can you articulate your ambulatory service strategy?
Sure. So for UHealth, I would say there's really two aspects to it. We're probably similar to others. We're a hub and spoke. So we have our main medical center, which handles our inpatients down in downtown Miami. But we really made an effort to grow our ASCs out into the community. So we have now our Lennar Foundation Medical Center, which is on our Coral Gables campus, which is a brand new 200,000 square foot ASC. You might have seen we also now are starting the development of a similar project in the Solomia development near Aventura, and we're also developing another one in Doral. So what we're doing now is going out into the community and developing more of these ASCs, and in addition to that, really we're going for growth. We think there's a good opportunity for us, given that we're a little bit different in the sense that we're a university-based health system in South Florida. So we're leveraging that to expand this hub and spoke model.
Dr. Rastogi, same question.
Thanks, Mike. First, I do want to say that I noticed that you vouched for the hospital, but you did not vouch for my golf game. Because we played golf recently, and so we were playing this the par 3 course. Unfortunately, I thought everyone was a par 5. All right. I think this is a very interesting time in healthcare. If you think about what's happening globally, for the first time in the U.S., 50.5% of healthcare with regards to revenue is actually delivered on the outpatient basis for the first time in history, and I think that trend is only going to continue to increase more towards the ambulatory. What's interesting about the dichotomy is we know that as patients, as we all live longer and get sicker, we are going to get more and more complex, so you're going to need more inpatient care. With that being said, with technology, and also technology both from a telehealth, that type of perspective, and also technology from the perspective of medical devices improving, we're able to do more and more on the ambulatory side. So we're actually in the midst at Jupiter Medical Center in the process of taking a look at not just what are our needs on the ambulatory side, the way we've always thought about it in terms of how many doctors' practices do we need or how many ASCs do we need, We're actually going through a much more thorough process, taking a look at what are we doing on the inpatient side that we should be moving to the outpatient side, and then based upon that, then we'll decide what do we need more from an ASC standpoint. When we think about primary care strategy, how much of that is going to be in brick and mortar versus going towards telehealth? So, from our standpoint, not only looking at what are we going to do on the ambulatory side, we're actually taking a look at what are we doing on the non-ambulatory side today that we should be actually decanting and doing it a different way going forward. I think the other component to that is going to be a lot of what's happening on the ambulatory side. There's actually an interesting article, I think, in the New York Times today talking about what's happening with retail players coming into healthcare. How do we partner with them? Because that's going to affect our ambulatory strategy as well.
Thank you. Terry?
So I'll remind you, as Mike said, we're a fully integrated system. So we take, we're certainly, our ASC strategy is based on similar reasons that the others are moving to, moving further out to customers and whatnot and decanting from expensive inpatient care. But we have a model really that's tied to our members. Our being an insurance provider, 13 million members, we know where they are, and most of it is tied really to the strategy around drive time and growth. So it's, we use algorithms based on, well, first of all, the driver regarding moving out of the inpatient, as I said, but, where do they need to be placed to serve our members best? And it's certainly not just an ASC strategy, because we will look at medical office buildings and provide as many services as possible within those medical office buildings. And so they just won't be, there won't be ASC alone. They'll provide, whatever services make sense for the drive time and for the demographics of what it is we're trying to satisfy with respect to meeting our members' needs.
Dr. Milne?
So for us at Providence, just kind of an idea of our scope, we have 51 hospitals across 8 Western states. And so the answer for us is a little bit market by market specific. So, like Terry, in our Portland market, we have a health plan. And so we have a similar sort of an integrated type of a model in that sort of a space where we're carrying full capitated risk. And so our strategy in that market becomes a little bit different than it is, say, in West Texas, where we have the major medical center in Lubbock, and we're serving essentially a 5-hour drive time radius around Lubbock in terms of where we're trying to capture in those markets, versus Anchorage, where we have the major medical center that's there, and we are the hub for this entire state of Alaska. And you can imagine, the fact that, the accessibility, if I've got somebody in Barrow or Kodiak or one of these other places of trying to get them in, what the ambulatory strategy looks like in those markets all looks a little bit different. And so that being said, in LA, where we're one of the largest health providers across the LA Orange County markets, we've got, our strategy is to be able to have access points across that density that's within about an 8 to 10 minute drive time of 80 million people across that, not 80 million, 8 million people across that space. And so as we walk through what those look like, it's a little bit of a retail of what we call express cares that are in a Walgreens type of a location. There's telehealth that's into that space as well. There's also a variety of electronic, app-based type of scenarios, urgent care, ambulatory surgery centers, and it's trying to provide the right access points with the recognition that generationally, how millennials are accessing healthcare and want to access healthcare is different than how a senior is going to be able to try and access healthcare. And so it's a broader spectrum into that. And as you're talking about here in Florida, you've got the piece of how do we move patients out of the hospital as well. And so part of this is determine where we put those investments of, do we build new inpatient pieces, or do we use more of a hospital at home type of a model to try and move that? And while it's not a traditional ambulatory play, saying providing hospital level care in someone's home becomes a key strategic part of what is our bed demand. How many inpatient beds do we need in any given market? And again, while not technically an ambulatory piece, it is a big part of that larger spectrum as we think about what the full vertical integration of care looks like from cradle to grave.
Thank you. So let me start with the question, Brian, how aligned is UM's real estate strategy with the ambulatory care strategy?
Fortunately, right now, we're quite well aligned. I mean, we've been able to execute on, what our CEO wants to accomplish in terms of, for us, and we're a little different, we're obviously smaller than some of the companies that some of the other speakers are here, but for us, it was really get out into the community and make sure that we find locations that we can tap for us with the right payer mix. And so far, we've been able to execute on that. I think the key now is, for us, some of these facilities that we're now developing, we're 2 years out. So we just want to make sure that, with that 2-year time delay, that, this real estate strategy that we've now started is aligned with the overall strategy of the health system. So I would say right now, so far, so good. We'll see in 24 months that everything ends up the way we have planned out.
Dr. Rastogi?
Certainly our real estate strategy is aligned with our health system strategy. I always tell folks that it used to be in decades past, if you're a hospital or health system CEO, you do a 10-year plan, in 9 years you could just hang out and then, you could redo the plan. Things are changing so fast in healthcare. I think that you can make maybe a 3-year plan and then every year need to refresh that. And I think the ambulatory strategy has to follow that. What I would tell you, even though we're aligned on the strategy side, there are changes that we need to make on the execution side. And a lot of that's because of what's happened in Florida because of the change in the CON law, right? So a lot of the things that we're executing on today were based upon strategies of a couple of years ago, but now that the CON laws have changed, and as we're rethinking some of our strategy going forward, again, not big changes, but some of the tweaks that are going to be because of that. And then number two, because of all the outside entrants that have come into this market as well, literally over just the past couple of years, all the consolidation that's happened, that's going to affect the way we execute on some of the strategies that we're putting on today. So what that essentially means is some of the ambulatory assets we were thinking about, now we're rethinking, do we want to do those differently? Also, with the CON laws changing, there's opportunities that are available now to us as well, not just to the outside folks that before we would not have been able to do. So because of that, we're looking to expand in other areas that we actually couldn't a couple of years ago.
Terry?
So again, we have pretty good clarity around our member base. Obviously, it ebbs and flows, that people don't stay forever. They only leave if they move, though. They would never move. They'd never leave the system if they didn't move. I wish that were the case. But frankly, we have a 10-year plan like most, a 10-year capital plan. But we have a great deal of alignment with our delivery strategy and service folks. They have the algorithms around the current members and the drive times and where the growth is. And they are also tied to our marketing folks. And so it's very easy to stay. When I say it's very easy, we weren't always aligned, but we have a direct link and a strategic plan from a real estate perspective, partnering with the delivery service strategy folks at our program office level, our headquarters level. And we also run that plan right through to the 8 regions and the areas within the regions as well. Now that plan is good for maybe a year. So we spend a lot of time throughout the year updating those plans, if you will, making sure that they're current. But it's helped us tremendously in making sure that what's requested at an area level is indeed aligned with what the regions want and where the program office level C-suite want to go. So it's not 100%, but it's certainly at least in my 4 years there, 4.5 years there, has proven to serve us well. And while not everything is approved that comes up to the capital approval committee, most do because and to a large extent because of that alignment.
Dr. Miller?
So I wish I could say we were as aligned as Terry is describing Kaiser being. I mean, our challenge for us across our multiple markets is that we still make a big chunk of our money on acute care hospitals. And so many of our administrators, their bonuses, their P&L is really driven by the acute care inpatient medicine, which we know is going away and shifting out. But because in most of our markets, we're not an integrated provider with our health plan. Portland's our one big market that we have that behaves that way. We're still looking at the demand for, do we need to build more hospital beds? At the same time, knowing that they're going to be obsolete here at one point. So there's an internal dichotomy, I would say, in terms of what our capital deployment looks like, and depends on which portion of the organization you're talking to as far as how they would answer that question. And so one of the ways we've solved it as an organization is we've stood up ambulatory as a separate division within our company with the express piece of they're going to compete internally with our acute care hospitals. And we're going to live in that world of a dynamic tension between our operating divisions, between the regions who are running the hospitals and this centralized ambulatory division that's running all of our urgent cares, ASCs, express care offerings across the system. And so we've intentionally created some misalignment that's there and created some internal competition between those aspects within the market as we're trying to disintermediate ourselves before Amazon or somebody else comes and does it for us.
Thank you. Over the years, I've learned my greatest and best lessons by making mistakes. No matter how many times people have tried to advise me over the years, I would continue to ignore that advice and then would trip over the curb. So, and then I learned my lesson. So I'm going to ask these guys, flip a switch a little bit, and ask, and of course, it's a theoretical question because none of you have misaligned strategies, but I'm going to start with Brian and ask, how might a real estate ambulatory joint strategy get misaligned?
So I think for us, you have, we're a fairly complicated system. We have a lot of, especially I think being a university based, we have a lot of silos. We have a lot of chairs of different departments going on and trying to do different approaches and implementing different strategies, and having them go off on their own, not talking to the other, and just having just a complicated organization and a lack of communication. We've had that happen before, and we've stopped ourselves before it got too far. But certainly, I could easily foresee a situation where we perhaps want to implement or go into a market where one chair believes that for their specialty, they can be successful, they go out, and then it's not aligned with the other departments. Because for us, we really try to offer a multi-specialty experience to the consumers. And I could easily see that happening where there's a complete misalignment and the system implements and goes through a process and something that's not successful because not everybody is involved and plugged in properly.
Thank you. Dr. Ostogi?
One of the things that I think about often is the old Peter Drucker saying, which is that in times of turbulence, it's not the turbulence that's a problem, it's trying to solve today's problems with yesterday's solutions. I do think that a lot of the misalignment that happens on the health system side today, because we're still thinking about the old world that we want to own everything on our own. I know we always think about the old build versus buy model, but what I would tell you is as health systems, we tend still more to err and have a bias on the build side. When I think about ambulatory strategy going forward, again, especially as there's so much VC and PE money coming into whether it's urgent care centers, ASCs, and so many different ventures that are on the outpatient side, what are the opportunities for partnership as opposed to trying to build and own everything on our own? Because again, that has definitely been par for the course for health system thinking for the past many, many decades.
Thank you. Terry?
I would say as well aligned as we are with a plan and a strategy to stay aligned with the strategy both at the program office level nationally and the regions regionally and the areas within those regions, there's still a lot of autonomy in our company. I mean, there's a lot of reliance on the regions to act on their own, to deliver on their P&L and to deliver on their growth. And within the regions, some of the large areas, there's themselves have a lot of autonomy. So there is, where we get misaligned sometimes is when, despite the strategy that we have in place, is regions will decide that they want to do something unique, something different, something that maybe isn't aligned with their own regions and within the headquarters itself. So that happens because of the autonomy that they've got, which is on one hand is good because they're empowered and they move forward and they succeed. On the other, with all of the changes in healthcare that are taking place, there does have to be, I believe, kind of a central organization that directs, how it is we're going to grow, especially with the cost of bricks and mortar in the areas that we're in, particularly California, well, the whole West Coast, frankly, and DC, and some of these other areas. I mean, it's an area where we could slip up. Having said that, all capital requests do come up to the headquarters for approval, and land acquisition, building acquisition as well. So we do have some control, but it does create an issue when you think that you're aligned throughout the whole organization, and you start seeing these requests that aren't necessarily aligned with the, with the 10-year plan or with the strategies that have been laid out, and you just deal with it there. Sometimes it's a little late, but you do.
Dr. Midlander, you touched on it a little bit, but anything else with respect to misalignment?
I guess I would echo pretty much everything that Brian and Terry have kind of reflected here in terms of misalignment of strategy. I guess the one thing I would add to this where we've tripped up in the past is getting the real estate deal ahead of the programmatic piece. And so we've had scenarios where local hospital exec is having breakfast or golfing with their friend who's the developer, and they've got a great idea for a new building to go up, and suddenly you've built a new building and we've master leased it to be able to secure the financing to make it all pencil on the development side. But we didn't have a real business plan of what we were going to do with it, and had a clear space. And so now we've got a big empty building that we've master leased and don't have a real, clear, piece of where this is headed. And so that's, I guess, the discipline that we're trying to instill into all of our local operators as they're trying to implement their growth strategies is, it's not build it and they will come sort of a process like we've done sometimes in the past. It's let's make sure we've got a really clear piece, and if we're building it, whether it's with a developer or doing it ourselves, we need to make sure that we really are tight on what the program looks like before we pull the trigger on the bricks and mortar.
Thank you. The panel, how much of your real estate and ambulatory strategy is affected by your competition? Start with Brian.
So far, nothing directly. I mean, there's certainly, more people coming into the South Florida market, especially with the change of the CON laws. But for us, again, what we try to do is leverage the unique aspect of us being a university-based health system. So, as I said before, we're a little smaller, so we have our one inpatient facility, and now we're doing this, I would say for us, fairly aggressive growth of the ASCs into the community. Competition has probably spurred that on even more, but I don't think it really has changed that much because we feel that we have a unique offering, or at least a differentiator with our offerings, and that hasn't changed our thought process in terms of this expanded growth of the ASCs and the outpatient facilities into the three-county area.
Dr. Stogie?
I think from our standpoint, it's definitely made us, much more disciplined. You think about competition, and thinking about your competition, it has to and it must always affect your strategy, right? I mean, who would actually start a strategic plan without doing a true SWOT analysis? So for us, as we think about the competitors, even from the health system side, or whether it's PE or VC, other folks that may be coming down the pike, what's that helping us think about is, so for us as a medical center and for our business, what is the business we want to be in? What is the business we don't want to be in? And how are we going to differentiate ourselves? And that's going to help us decide, and that is helping us, actually execute on our real estate assets and our strategy as well.
Thank you. Terry?
Yeah, I would agree with Emmett. I mean, if you're not aware of what the competition is doing, you're going to fail at some point in time. California is not as competitive for us, although, we certainly have to be aware of what the competition is. But especially the regions outside of California where we don't have, the same brand recognition, we don't have inpatient facilities. It's a huge factor, very big factor in determining, how we're going to grow there, how we're going to deliver services, where they're going to be. So it's a very big factor.
Similarly, I mean, the competition is driving a lot of what we do in terms of how do we make sure that we're positioned in the market to be able to compete for market share effectively. And a large part of our ambulatory strategy is about trying to stay ahead of our competition. So I mentioned before, we've stood up ambulatory as a separate independent division within our company that spans system-wide with the intention that we're trying to disintermediate our hospitals. Well, that doesn't work in terms of from the economics if we're not also disintermediating our competition. And so that's the question is as the shift moves into a much more ambulatory process, can we be ahead of the curve to be able to catch that as that migrates out of the hospitals and be able to be ahead of where the competition is with that. And so as we're deploying those assets, is a real strategic look of which markets do we have potential there versus which ones we don't necessarily.
Thank you. Next question is sort of two-parter. It's how often and you each mentioned 10-year plans. How often does the strategy change? Does it change as a result of changes at the top of your organization? And does it changes due to changes in macro policy, such as Dr. Rastogi referred to the changes in the Florida C of N statute? So, Brian?
So for us, our strategy has changed. I've been at UM and UHealth for just about 6 years. When I was first there, we were much more conservative in terms of our approach. With our new leadership that's been in place now for a few years, as I've said, we've become much more aggressive in terms of our growth plans and getting out in the community. As the leadership changes, if it changes again, is it possible? Sure, but right now I think we're pretty committed. We're a little different. We have more of a 5-year plan for our capital, and that's certainly what we're focusing on now, and I don't see that changing based on, the investments that we're making right now.
Dr. Rastogi?
You had two parts, and I'm going to try to address the second one first, which is, does the strategy come from the top? As the CEO, I can tell you, I sure hope it comes from me. Hope it's not coming from somebody else. Obviously, you have a board that you work with on that as well. With regards to how often it changes, and I articulated this a bit earlier, I think that in healthcare today, at least from my standpoint, I tend not to go out more than 3 years. I try not to stray from that too much, but you do have to have a 1-year refresh, because the reason I don't want to stray too much beyond that is we've all been in organizations where CEOs got a new plan every day. The problem with that is the strategy to execution gap just gets greater and greater, right? Then you don't really have a plan, just being reactionary on a daily basis. So I think some of that comes down to the style of the CEO and the style of the management team. Again, from my standpoint, what I try to do is have a 3-year plan, and then on a yearly basis, just, again, assess the competition, assess opportunities, but then give the teams time to actually execute on the plan as well.
Thank you. Terry?
Yeah, I would say that the 10-year plan definitely gets adjusted, and it formally gets adjusted every year. And there are certainly tweaks and, that end up changing, when and where we're going to perhaps put an inpatient facility. MOBs are rolling out pretty regularly. As to changes as a result of leadership, we're about to find out. Bernard Tyson, our previous CEO, just passed away. And it's impacted all of us in a very large way, but Greg Adams has taken over, and so this is the first time I will have experienced a change in healthcare in leadership at that level, CEO level, and we'll see. I suspect that because of, how we structure this strategy, it's not going to change dramatically, but we'll see. I do think that, technology is going to have a bigger impact than certainly the leadership will have, but that remains to be seen as well.
Thank you. Dr. Milne?
So for us as an organization, I've been in my role about 2 years now, and I'm part of the change that kind of brought along that strategy piece. My boss, who's the CFO, was brought in about 3 years ago, and that really marked kind of a sea change for us as we start really kind of rethinking that. And so my boss, Venkat Bhattacharya, came from Microsoft, is bringing a different lens to it. We're bringing in a variety of other senior execs from Amazon and other types of outside influences that are new to healthcare, and in a very intentional way, looking at how do we change what our strategy is and how we're deploying capital. So we're in an ongoing evolution, but from that, really more push into an ambulatory focused space. That being said, we are constantly course correcting to a certain degree. Our regions have every 6 months we do a kind of a summit basically with each one of our regions as far as where your strategy at. Let's check in on where we're headed, and so it's not major radical shifts, but it's a recognition that we need to kind of do the dipstick test every 6 months or so and say, are the assumptions we had 6 months ago, are they proven to be true? Are there course corrections that we need to make? And that's been a relatively newer phenomenon for us, is to be trying to, at a regional level, reassess where we're at strategically. And none of those regional strategy sessions produce massive shifts. We're not radically changing course on any of those, but it's the fine tuning and constant course correction based on changes that are both micro and macro in the markets.
Thank you. The changing consumer purchasing practices have certainly changed over the last few years. in the days leading to the holidays, when I would come home, I'm tripping over Amazon boxes all over the place. And that has led to what I think are repurposing opportunities at mall locations, larger shopping centers. I'm wondering if...
Especially in Broward County, but nothing materialized that made sense either for us as a possible tenant or the landlord or even a possible joint development. We are exploring it though because we do think it's a good opportunity. Certainly in terms of some of the facilities there and parking, which might be another topic we talk about. Parking is always an interesting challenge. So we just haven't found an alignment yet, but we are certainly open to exploring it.
Dr. Stogie?
Sure, I think the way if you want to be successful with that lens is to think about what does the patient want and what does the patient's consumer want. So I tell you, on the urgent care side, our busiest urgent care center, probably no accident, our most profitable is next to the busiest Publix in, I think, all of South Florida or all of Florida, because that's how urgent care center traffic works. Now, if you take that into the MOB model, which means primary care and specialty care, to get this a little bit different, right? So if you look at what the patients as consumers want out of a medical office building or multi-specialty care, is to really have one-stop shopping. Now, unless you're going to have a space in a strip mall that's going to be able to house enough square footage to have a true multi-specialty office with imaging, which I've seen less and less of, it's usually, again, just enough space to have one office or an urgent care center. I think from a multi-specialty side, that's probably where we would stay away from at least that type of retail space.
Terry?
Yeah, we've done a number of experiments so far, and very small primary care is about all we've got today. We have, we've gone to strip malls, 3 or 4. We've certainly located in areas where it's really important for us to be in a certain location, perhaps to attract a commercial client as well, commercial customers. And we've had discussions with some of the larger mall developers and owners who, are looking to look at this multi-purpose and mixed use, if you will, to try and regenerate some of these areas. We haven't gone in a big scale, but we've certainly had discussions and they're ongoing.
Dr. Milne?
So, we've got several examples across our system where we've repurposed, former big box stores into, clinics of various types and scales. And obviously, we've got the small, micro walk-in urgent care clinics in a strip mall, traditional kind of retail sort of a space. The other piece, though, that I think doesn't necessarily get discussed for us is actually our office space, where our administrative spaces are at. We have a converted movie theater in Portland where we have a large IS team based in that space. And we just lost a lease to Amazon, where to take down 110,000 square feet of what was formerly a Macy's department store in a major mall in the Seattle market. And the reason we're looking at those types of spaces is as we're trying to attract labor and attract talent into the organization, we actually are competing with Amazon and with Microsoft for a variety of types of administrative employees, whether some of it's software development, but also accountants and other, attorneys and other, professionals that get used across our industry in various ways. And so we look at retail space and converting it from an office perspective comes with instant built-in amenities that are there in terms of food service and entertainment and parking and walkability and a variety of other things that become attractive for us as we're trying to compete in terms of what our office space locations look like with talent across our markets, and particularly given that we have large concentrations of administrative employees in the Seattle and Portland markets in particular, where we've got large administrative hubs and that, very tech heavy. So our competition, our job market is very tight there as we're trying to attract employees.
Thank you. Next topic is near and dear to almost everyone in this room, which is third-party ownership of facilities through which you guys deliver healthcare. What's your attitude towards it? Do you embrace it? Do you tolerate it? Or do you want none of it? Brian?
So for us, there's kind of two aspects to look at it. First, we're a tenant in a good number of our facilities. It just works well for our model in terms of providing some flexibility, and in terms of organic growth, it's easier for us to accomplish it that way where we're the tenant with a third-party owner. And then the second aspect is, a joint development, looking at some of the larger facilities that are now in our pipeline. So we're not against it. We've explored it. We're going to continue to explore it. For us, it's always a pretty simple calculation. We can, as an institution of the University of Miami, we can float a bond. We know exactly how much our cost of capital is for us versus a third-party private provider, and we're normally cheaper. So we're always doing that calculation, but as time goes on and as we continue to grow, we're certainly interested in exploring that option, and I know our CFO is very interested in that. So even though we haven't actually done a large deal yet, it is something for us that is certainly on the table, and we will continue to explore as we move forward.
Thank you. Dr. Rastogi?
I always tell my team that I'm kind of like a born-again millennial, so I'd like to own nothing if I could. I'm not just joking about that, but the reality of it is that I think that, for any of us, we want to approach a decision-making matrix. Certainly I have the approach that if there's a real estate need we have, let's look at the universe of options of how we could achieve that, whether it's third party, whether it's ownership, leasing, joint venture, whatever it is. I think at the end of that, that's when you come to the best decision. So I don't have a bias one way or the other. My style ends up being, let's just look at and see who's going to make the most sense out of it from a deal perspective.
Thank you. Terry?
Yeah, so I'm normally the least popular guy in the room when it comes to, partnering with developers and third-party capital, because we have had an ownership bias now for several years. The markets that we're in particular, you're leasing in those markets, 10, 15 years later, it's very difficult to argue that at $800 a square foot that you're going to move. That threat is kind of hollow. So we definitely look at owning first. Unless we're in a multi-tenant facility, if we're looking at behavioral health, mental health in an area, if it's a relatively new market beyond where we are, we're extending. Sometimes we'll lease there as well. But for the most part, as Brian suggested, we know what our hurdle rates are. We know what our cost of capital is, and we base it on that. And the first question that the CFO asks me when I bring a case forward is, why aren't we buying it? And I've got to answer that as opposed to the other way around. And Treasury is in the same position. They're right behind me.
Thank you. Dr. Milne?
So given the diversity of our portfolio and whatnot, we've got probably every flavor of deal you could imagine sitting out there, from complete lease to owning and building that process. And so as we trying to approach it, similarly to what was mentioned before, is it's a little bit of a right tool for the job is the philosophical piece that my team has across there. And it continuously evolves. So, what is the cost of capital today versus where it's going in the future? What is our, long-term strategy in that market? What's the size of the space that we're looking at in a scenario where, it's small, urgent care piece is probably more of a lease in an existing spot. Are we going to be a multi-tenant, or are we wanting to take the entire space of a building? And so all of that changes the calculus for us. So it's really a project-by-project decision base for us. There's not a one-size-fits-all.
Thank you. Let's turn to digital or virtual healthcare. Have each of you developed strategy around it? And the second part of this top question is, what do you think in the long term the impact will be on brick and mortar? Start with Brian.
So we're starting to. We're probably a little behind some of the other people up here. But telehealth is something that we are absolutely looking at and developing strategies around. As we do our planning for the different real estate facilities, we are absolutely taking telehealth and digital medicine into account. For us, I was actually talking with one of our operations folks, and we have something, just as an example, called UHealth Chart, which allows all of our patients and customers to access. We see it as a supplement right now to the main facilities that we provide. So it's going to continue to move, and we know if we want to stay competitive, we have to move more and make more advances towards it. So right now we're planning for it, and as time goes on, it's going to be a larger and larger component.
Dr. Rastogi?
Let me ask the audience a question by show of hands. How many folks here have actually tried a telehealth tool? Quite a few. Yeah, you are part of the audience too, by the way. So when I was at the Yale New Haven Health System, I'd actually helped launch the telehealth tool there. So as part of that, as a physician, I had to try it both as a doc and a patient. What I would tell you is, for the first time I tried it as a patient, I said, boy, I would never go to the doctor's office again. Why would I want to drive an hour, sit there for 2 hours, when actually can take care of this issue in 5 minutes over a telehealth platform, whether it's televised or whether it's just by voice. If you look at the patient data, it actually shows that 85% of people who've used telehealth continue to use it again. I think the rate-limiting step in telehealth has not been the technology. The technology has been around probably for about 8 or 10 years. The rate-limiting step really has been the regulatory environment and the payer environment. That's why if you take a look at vertically integrated health systems, such as the folks sitting next to, on my left-hand side, they're much more advanced on that platform because they don't have the payer issue, and they overcome a lot of the regulatory ones in their state, mostly because of their size and ease of implementation as well. So I think going forward, from a real estate strategy standpoint, it is definitely going to make our approach much more asset light, because there's more and more we're going to be able to do, because both the regulatory hurdles, even in places where folks like us who are not completely vertically integrated, are going to be able to implement the strategy, and also from a payer perspective as well.
Thank you. Terry?
Yeah, so, given that we are an integrated system, we invest heavily in technology, and we look at preventive measures, because quite bluntly, we are more profitable if nobody comes to our facilities, right? Because we're serving our members. We're not, we're not a PPO. We do invest in it. But we've had no significant deviation from the strategy or change in terms of the bricks and mortars that we see having to build. We've got an Office of Transformation that's looking at this on trying to stay abreast of it, trying to understand it, because we all know that the investments that we have to make are big, and they last a very long time, and then you've got to maintain them. So we're trying to get a grasp of it, try to understand it, but at this point in time, there is no significant deviation from the bricks and mortar strategy around delivering healthcare. And I know that's going to change. I can't tell you when, obviously, but neither can the company at this point in time.
Thank you. Dr. Milne?
So, multifactorial answer. So we've been all in on digital for probably about 8 years or so now, and have a very aggressive process around how we're looking at it. And so to break it down into multiple component parts for us, saying telehealth is not a one kind of solution sort of piece. So we look at what our B2B solution is in terms of internally how we're managing those sorts of processes, where it's not a direct-to-consumer sort of a front. What it allows us to do is we're doing a whole variety of specialties via telehealth that are allowing us to extend those services into other facilities. So psychiatry is one that is there, where we don't have enough psychiatrists necessarily across our system, because in terms of the labor shortage. And so rather than trying to consolidate all the patients into one psych facility, we're able to distribute them out and allow the psychiatrist to round on those patients in a virtual sense, and using that inpatient capacity in a more distributed model. So it does change what we need to build from that perspective. We also have a very specific set of DRG codes around medical care and moving into more of a hospital at home process. We've got a number of pilots that are going forward. It hasn't yet influenced specifically what our bed demand studies are looking like, but we are programming those DRGs that we are expecting to move into a hospital at home model, where it's the elderly patient with pneumonia who you're able to manage in their home with smart technology and medical devices that normally would have taken up an inpatient bed. And so decreasing our med surge capacity ultimately, and we're going to increase the total acuity that's in the hospital, so you've got more ICU beds relative to traditional med surge ratio there. So that is an influence that we see hospital at home coming down the pipeline as far as influencing that. In terms of the consumer-driven telehealth, which is kind of competing against an urgent care type of a model, or even some of the primary care pieces, that actually does change in terms of the spaces that we need to house those teams. Now, am I needing it in a telecenter, in a centralized location versus a distributed clinic network? So we are looking at how those pieces affect things as well. But then on the more of the innovation side, we have kind of a three-armed approach around digital innovation, I guess is the way to describe it. So we've got a Providence Venture Group that is out there actively investing in new companies specifically and startups that are specifically targeting these types of markets. So for example, one of the companies that's come out of the venture group is called Zelf, that you may have heard of, and it basically is a company that allows integration with your EMR to be able to allow a physician to prescribe apps that are health related, and being able to provide a digital ecosystem for the deployment of apps as pharmaceuticals effectively. And then, if you look at, and there's a variety of other companies that are coming out of that venture group. We then have essentially a private equity arm within our piece that is working on acquiring and bringing into our ecosystem companies that are more mature and that ultimately are complementary around it in terms of where we see the need for digital innovation going. And then the third piece to it is, if we don't find a company that's already doing what we're trying to do, whether we're seeding it from a venture side or acquiring it, we have a digital innovation group that's going out and natively writing software. So we've got teams of coders and developers who are actively going out and saying, we need this tool to be able to affect the market in this way, and they're building the software from the ground up to be able to do that.
Thank you. Next topic of discussion, behavioral health, and if I may be permitted to call it, or what had been at least, somewhat of an isolated healthcare delivery service. I'm wondering now, with the growth of behavioral health, with the aging of the baby boomers, with the growth in the incidence of dementia along the way, have you made it more core to your real estate and ambulatory strategy?
So we've tried. It's interesting. We were exploring doing a joint venture with a private behavioral health provider. But what we kept encountering from a real estate perspective was not in my backyard. Every municipality would really put up a lot of roadblocks, and it was incredibly challenging. And maybe that's more, maybe it's unique to South Florida, because we do have some local behavioral health facilities that have pretty bad reputation. So even though we came in as UHealth and our reputation is quite good, it didn't matter. We would meet with a number of different local municipalities. We talked about what we'd want to do, and they would just say, no, we are not going to go for this. Our zoning doesn't approve of behavioral health. If you want to do your regular services, that's fine. But behavioral health, we're not interested. So far, we have not been able to execute on that strategy, primarily due to the pushback we've received from the local, either the local population or the local municipalities.
Dr. Stogie?
Mike, I think you did a good job of differentiating the definitions or the needs of behavioral health. When I was in New Haven, it was much more about addiction and some of the behavioral health issues surrounding that. Certainly in this market, it is much more along dementia or age-related memory issues or social isolation. From a strategy standpoint, and there's actually an interesting article in The Economist, I believe, a couple of weeks ago, and what they're talking about is how in the Netherlands, to address a lot of those issues, they actually had this picture, it's a great picture of a social worker sitting there, and she had a split screen of 5 elderly folks who are actually having a conversation with each other using a telehealth portal. From my standpoint, as opposed to, and obviously as dementia gets advanced enough, at some point you have to have folks in a facility where they can be cared for full-time. But I think right now where a lot of these in-between steps will be actually much more better served by having a care-at-home type of strategy.
Thank you. Terry?
Yeah, we've had a major push on to deliver a lot more behavioral health, mental health facilities within our regions. And since I've been there 4 years, I would say we've brought on 20 new facilities. We've got the challenges that Brian outlined. Obviously, not everybody wants it in their backyard, but we've been pretty successful. Most of those are leased locations. We've got a few owned ones, but we're definitely reaching out into the community, and we're certainly expanding our reach as well. In my opinion, we haven't well served our members in that way, but as I say, we're making a significant change to ensure that we do provide better services to all of our members.
Dr. Milne?
And I think Emmett touched on it well in terms of differentiating the types of, there's kind of three broad classes, I guess, of behavioral health. There's, the substance abuse addiction services, which frankly we don't do well, and as a real hodgepodge mix to what that looks like. Then there's true psychiatric care, the schizophrenia and depression and a variety of other, what we think of as the true mental health illnesses that are there. And that set of population uses a different set of tools. And I mentioned kind of before our use of telepsychiatry in that way is certainly changing that. And we've partnered with a variety of third-party providers around that, and so it's an ongoing evolution for us in terms of how do we get our arms around it. And then the big third one is memory care and aging and geropsych type of issues, which are a very different population than the traditional psychiatric population. And so we need to think about that in a different way. And we don't frankly have a good cohesive strategy where we're at. I think we share a philosophy, probably with many of you out here, around aging in place and trying to have the right facilities that keep people, rather than institutionalizing them. How do we keep them at home as long as they can? How do you maintain spouses together as long as they can, and the stability that provides there? And so having the right housing for them, the right services to be able to provide that's an ongoing conversation within our organization.
Thank you. We have about 10 minutes. I will leave a few minutes at the end for questions. So this will be the last question, two parts. One is, what happened in 2019 that surprised you? And secondly, what do you expect to happen in 2020? Brian?
So, surprise might be too strong of a word but what I was thinking, again, from a real estate perspective, focusing on the three counties here in South Florida, which is our area. I was anticipating the rental rates, because we are a tenant, not to be as aggressive as they were. I thought there'd be a little bit of a softening in the market, just given the length of the growth that's occurred in South Florida, and really it's still been stable. So my bosses are always disappointed because they're also expecting lower rates, but so the stability of the market is a little bit of surprise, at least not, maybe we thought there'd be a little bit of a softening. In terms of 2020, I might amend it. It might be 2020 or a little bit beyond. Seeing a number of private equity firms have been meeting with us and a lot of different investors. They're talking about a WeWork model for healthcare. We will build out the system, and then you as the docs can just come in. I suspect that's going to play a larger and larger role. Maybe not quite this year, but I think it is going to play a role in the next few years to come, because I think that is an area that a lot of different companies are looking at.
Thank you. Dr. Rastogi?
Going to comment on what Brian said about the WeWork model. We already know that's been an issue for the non-healthcare folks. We'll curious to see how that plays out on the healthcare side. With regards to 2019, and probably surprise is the wrong word, because of discussion that's been going on all over the country for the past many decades. But still, when there's a big change such as CON, the need for CON getting repealed, and again, you're not surprised by it because you start reading on the tea leaves it's going to happen, but it does affect how you're thinking about certain things going forward. So along those lines, when I think about 2020 and beyond, it really is, what is the implications that's going to have for folks, whether it's a WeWork model that people bring in, or private equity coming in, or just the outside entrance, and how's that going to affect us. So I think those are the things we think about in the next couple of years.
Thank you. Terry?
Yeah, rental rates, again, San Francisco Bay Area in particular have just been crazy. And we were fortunate on the lease. We lease in the order of 18% of our portfolio, 90 million square feet. And the San Francisco Bay Area in particular, we were fortunate to do a lot of leases, during the recession. And they're coming around now at 2-3 times, what we're paying today. So that was a bit of a surprise. As has been the growth in Oakland. Our headquarters is based in Oakland, and we've been kind of an island there. San Francisco, all the technology's on the peninsula for the most part. East Bay and Oakland hasn't been touched by it. We've got around 7,000 administrative back office employees in Oakland, and it's been kind of protected. We're in a bit of a bubble where we haven't had to compete in the past for talent, if you will. And, they've since, I think we've got in the order of 15,000 new residential units that are under construction, and there's another 10,000 or so that are in the pipeline. Commercial has expanded dramatically, a lot of new commercial buildings in place, and that has been a bit of a surprise, well, more than a bit of a surprise over the last 2 years. And it's changing the dynamic, how what are we going to do to deal with that? And the other, well, 2020, certainly the surprise for me is, getting some kind of clarity around when the next correction is going to be. And I'm not certainly forecasting it and not wanting it in 2020, but it's always been a bit of a, I've been listening to economic forecasts since 2015 that have forecasted the next 2 years. And I hope they're all wrong forever and that we never get there, but it's got to come at some point in time.
Dr. Milne?
And I guess I would just, add on to what Terry was saying. That was kind of my surprise for 2019, and Brian touched on it as well, of with a flattening and inverted yield curve, that, I was expecting we were going to see recession, starting to creep into the market, and then obviously softening of what the real estate market looked like by the end of 2019, which, at least in the Puget Sound market, for us is as overheated as it ever has been. So, are we in the middle of a bubble around commercial real estate in terms of what our supply looks like? Maybe. It's hard to say right now. So I think we're waiting for that. Hopefully, as our leases kind of expire, the ones we negotiated 10, 15 years ago are coming due. It's a matter of how do we relook at what that's going forward. I guess as far as 2020 goes for me from a real estate perspective, we're spending a lot of time talking about what does the hospital of the future look like for us, and what does that move forward. And I would argue that in many ways the hospital of the future is multifamily housing. And as you're talking about before, of looking at what does hospital at home mean for us, how do we deliver care in a more ambulatory space, how do we allow people to age in place, a lot of the pieces that we've touched on, the platform to do that is where people live. And how do you create the living situations for people that are integrated into what the health system is doing, how they're driving it. How do we make sure that we've got the platforms that allow patients to age in place? And we currently don't really have strong investment in that. As we look at how do we drive forward, housing and equity are big issues for us in 2020 going forward, all the way from true low income scenarios, really all the way up into workforce housing, and looking at a variety. And so we've got a variety of concepts, I should say. They're not even at the project level yet or on the drawing boards of how we're looking at housing, and we've got pilots around tiny homes in some of our markets. We're having conversations around what container houses look like as potential solutions to some of pieces. We're looking at a variety of redevelopment projects. We've got one of our campuses that currently has senior living on it, that we're looking at a both market rate and some high-end potential condos onto a property that would then help support some more lower income, as we have a mixed economic model within a project or with a property. And so we're looking at a variety of those sorts of pieces across a wide swath to be able to address multiple factors as we see housing as a huge part of the social determinants of health, and a platform where we as real estate can help kind of influence where the system's going in that way.
Thank you. So I'll open it up to questions. Go ahead.
So, great question, and short answer is it's really at that latter piece of where it is that we're headed. So if you look at Portland is our most vertically integrated market, but unlike Terry, we're not 100% vertically integrated. So even in Portland, we've got our standalone hospitals that are, it's really a part of our health plan or part of our network and completely, we're at risk for, and so essentially our members in that market. And on the same chassis, we're trying to serve a fee-for-service population as well, which creates an internal schizophrenia, as you can imagine, that's there, which is difficult. And so, but the advantage of that, as I see it for us, is you're right, it does create a learning lab around that in terms of innovation, because fundamentally what we need to do is drop the cost of care. No matter who's paying for it, we need to drive down the cost of care. And so no matter what market it is that we're in, the solutions that are going to work in Portland, where it's a capitated market or more capitated market versus West Texas, which is our largest fee-for-service market that's there. The fundamental, if I can get my cost of goods sold effectively down, I'm in the business of selling RVUs, so if I can figure out how do I produce those RVUs at a cheaper cost, that's fundamentally good business. And so that's where we as a real estate team are looking at how can we fundamentally drive down the cost of care in all of our markets, no matter what that looks like. And so that's where the conversations that we have with developers is how can you partner with us to actually share some of the risk? How do we look at innovative models around what is fundamental to our business of how do we provide care cheaper? Because as a nonprofit, our goal, we're very mission focused, and our mission is to be able to provide health in our communities. And how do we develop platforms to be able to do that going forward and be able to provide it at that lowest cost point?
Thank you. Yeah.
Yeah, so, the way that we think about it, and you're right, primary care and urgent care centers for the most part are not big money makers. I remember, one of my mentors at Yale used to tell me, just remember everything can't be a loss leader. You got to actually have something that makes money. But what we know is that, first of all, if you think about in the U.S., the biggest need we have from a physician workforce planning standpoint and from provider standpoint is really the need for more primary care. So the way we think about it is we provide that access, and some of the losses we're able to offset by helping that feed into some of our other lines of business, whether it's subspecialties, imaging, or surgery, which at least has some margin. We know nothing in healthcare is a great margin today, but at least it has some margin. With regards to your question of how much of a premium, it really just depends on how much volume we think we can drive in the site, right? So the premium is going to depend on if you think you generate enough volume in that site, that can help you generate business for your not just provide the access to the primary care, but help you generate business for the other service lines. It really is a very individual decision depending on the site.
Thank you. Yes, Mr. Mitra.
Eventually, you have to debt cap.
So for us, on the larger facilities, we generally don't lease. A lot of times where we employ leasing, I think it's similar to some of what the other gentlemen were saying, is smaller facilities. We want to get in there quick. We're one tenant in a multi-tenant building. And again, to the other question, so far, when we've done the calculation, and again, it's not a complicated calculation, we have decided to float the bonds to do more major developments. I think what it is then, as we move forward, it's evaluating the real estate risk. Is it something where you perhaps do need to be nimble. Maybe, as technology changes, you take an example of CTUs. Maybe down the road, you don't need to have CTUs. Maybe the administration of oncology has done it a different way. So you have to be somewhat flexible with your real estate. So having a lease allows you to do that a little bit more. I mean, look, let's be honest. You still have a lot of capital investments that have to go into any facility. But doing a lease does help from time to time in terms of having that flexibility and limiting the risk. But on the larger facilities, generally, when you're talking about, 200, 300 basis point difference, yeah, you float the bond.
Terry?
Yeah, I mean, you raise a great point. But we are doing just that. We are taking a bet that, I guess we're aligning more with what Spencer Levy said yesterday around interest rates. And, I don't know that that's a detailed calculus, but, two things are happening in our company right now. First of all, cost of construction in the Bay Area is, in particular, not just the Bay Area, but California, is astronomical. And, we're forecasting between 5 and 7% increases annually right now. That doesn't mean that we can't use third-party capital, but we're taking a much closer look at our infrastructure and the number of changes that folks have tried to institute over the years. In other words, this facility no longer serves us, we're going to replace it. And what we're doing is we're taking, frankly, a 50-year approach to owning our facilities. And so over the next 50 years, I mean, you tell me, where are we going to be? I don't know, but that's certainly the approach that they're taking. This is largely a treasury decision in our company. I've never experienced it. I came out of technology, and we certainly didn't have that same approach. Having said that, most technology companies will take certainly an ownership approach to those facilities that are expensive, their manufacturing, their data centers, et cetera. And our MOBs and inpatient facilities are at least as expensive as data centers. Third-party capital, we didn't do it in technology very often either, and we're not doing it here. Whether that's the right approach or not, I guess time will tell.
Thank you. Went over a little bit. I want to first of all thank you for your attention. Appreciate it. I want to thank the panelists for their insight. Really appreciate your time and your thoughts. So thank you again.